So it is, okay, is this, can you hear me? No? Yes? Okay. It's such a beautiful day outside. I apologize right off the bat for like 90 minutes inside this room. So I'm going to try and make this go by as fast as humanly possible. And we'll see how that works. I will show slides, as all physicians do. We're incapable of talking without slides. And we'll get started. So we're going to talk about the HIV pandemic and its prevention and where we are. And a lot of this is like going to be predicated not so much on, some of it's 2012, some of it's going to be at 2007, 2009, and that's kind of not accidental because we're undergoing a dynamic change right now in this epidemic. And that it's an important and in many ways positive dynamic change. So if we, in 2009, when I first made this slide, it's like, where are we now? How did we get here, and where are we going? And all of that I'm going to tell you on a global basis, but with some detail on the United States as well as we go forward. So all of this starts with what would seem to be like nothing. I was a young infectious disease specialist. In fact, let this be about me. Narcissism is my middle name. Let's start about me. Here's me, and this is my wife who's on the faculty named Gail Henderson. Here's me with a bunch of Chinese guys and women at Hubei Medical College, all this hair, which I really like looking at all the time. Here's me when most of you, I was about 30 years old then, most of you weren't born when I was in China doing this work. And at that time, that report that I just showed you was about just right after I came back from China to Chapel Hill, about a very small number of men who have sex with men who acquired an unusual infection called pneumocystis. And no one anticipated that this would be the galvanizing pandemic of the 20th and 21st century. And I certainly never anticipated living in China, minding my own business, and God knows why I was in China, that's a whole other story. But I never anticipated I'd spend my entire life working on one problem. So as we go through this, remember this is a story about an epidemic and a pandemic that's gone on for 30 years, which is evolving, and many of the people on the faculty have been working on this the entire 30 years. So this is not the fast track, okay? This is a commitment to work on one problem for a very long period of time. So where are we now? Well, one of the problems we have is the US. That we have about 1 to 1.2 million people infected in the US. The CDC had almost persistently estimated about 30 or 40,000 new cases a year. Recently, they upped the US epidemic to between 50 and 60,000 new cases a year, and many of the new cases in the US are in the southeastern United States. A large number of the problem lies not in the urban areas, but in what we call rural AIDS in the southeastern United States. And if we look at how this is composed in the United States, and these are these pie diagrams you'll see over and over, you'll see that a tremendous amount of the transmission, and this is very unfortunate, lies with men, especially men who have sex with men. And in the southeastern United States, that's especially a problem among men of color in the southeastern United States. There are a lot of social forces that allow this problem to persist in the United States. We also see HIV growing rapidly as a problem in women, and again, especially in the southeastern United States. And in many ways, this isn't surprising because men who have sex with men are not necessarily homosexual, they may be bisexual. So we have a bridging event between men who have sex with men and women driving this problem in the United States. In all candor, we've not done a great job in dealing with the HIV spread in the United States, and the US is trying to redouble its efforts, and I'll come to that, with a lot of different strategies to try and get a handle on this and reduce the number of cases. I can tell you right now as we go through this lecture, and maybe Ron or others have already talked about it, one of the things that drives the epidemic is stigma. Stigma, fear of your behaviors, which are your own behaviors, fear of the stigma of having a disease. We used to be afraid to tell people we had cancer. Now people are afraid to have an HIV test, and so on and so forth. That stigma helps to drive this. There's a woman on our faculty, if you're interested in this topic, named Ada Adamora, who studies HIV spread in the Southeast. And I would really recommend you look at her work, which is very thoughtful and looks at social forces that allow the US epidemic to persist. If we leave the US, and by the way, so the US is never going to have a gigantic epidemic. It's going to have a modest epidemic. There are going to be 1 or 1.2 or 1.3 million people out of 330 million people. I don't think that's a small problem, but it hasn't grown to enormous proportions. If we look at the global pandemic, and I look at 2007 specifically, because this is a special year, we then see there are a lot of people worldwide infected with HIV, more than 30 million. We see a lot of new people infected every year, and we see lots of deaths every year, and we know by 2007, more than 16 million people had died from this infection. And I can tell you from my own personal experience, for many of us who work in Malawi, years ago, as a cautionary note, when you drove from the airport, how many of you have ever been to Malawi? Many of you. When you drove from the airport to the hospital we work, there were nothing but coffin makers. So the entire row of shops were woodworkers making coffins. We'll come back to that as we talk. Why do I focus on 2007? Because that's almost a transition year when the spread of HIV started leveling off. And so instead of it becoming a pandemic that's growing endlessly, it levels off at between 30 to 40 million cases. It's a lot of people. I'm not saying that's not a lot, but it's not constantly and logarithmically going up. It's starting to level off, and in some countries you're starting to see a fall in the number of new cases of HIV and even in the prevalence of HIV. That must demonstrate something, and we'll talk about what it might demonstrate if we ever get that far in this discussion. So more than 96% of people with HIV infection don't live in developed countries. They live in low and middle income countries. About 1,200 a day are infected are under 15 years of age. About 5,800 a day that are infected are greater than 15 years of age. And most of the spread worldwide is heterosexual sex. So this is not a thing that we don't all, most of us, I don't want to speak for everybody, most of us participate in this activity. It's not an unusual activity that's leading to the spread of HIV, most in poor countries, and about 80 to 82% of all HIV is in one small area, sub-Saharan Africa. So we have to ask ourselves, how did this epidemic get so grave in sub-Saharan Africa, and what are we going to do about it? And this is a slide that kind of demonstrates that, a worldwide slide that shows all this distribution. And you see a huge number, more than 23 million people now living in sub-Saharan Africa infected with HIV. So where is HIV going next? Well, as I said, it's decreasing in many parts of Africa. Is this because all the susceptible people who could get infected have become infected? Very unlikely. Is this because prevention efforts that have been honed for 30 years are taking hold? More likely. And also leading us to conclude that we can do more. HIV spread in China. Even a tiny little thing that happens in India and China is a huge deal. So let's think about that for a second. With 1.3 billion people living there, if 1% of the people have a problem, that's a huge number of people. And China estimated that they would have an epidemic of greater than more than 10 million people. That's not happened. Their epidemic in China remains modest. Russia, another big country, but mostly an epidemic in intravenous drug users. And I suspect that one of our greatest fears is our not knowing how big the problem is in India. We know there's at least 5 to 7 million people infected in India. We don't know how rapidly it's growing in India, but India is a place where a lot of people are looking for new and ongoing problems. So we have a pretty good handle of the global epidemic, not a handle of that it's over, but a handle of where it came from, where it is now, and to some extent where it's going. Can you all understand me at this rate of speed? Okay, I'm going to talk faster then. I will get to a rate of speed where no human can understand. Now, how did we get here? This is the most important formula you're going to hear. And how many of you saw the movie Contagion? Okay, how many of you saw the movie Outbreak with Rene Russo and Dustin Hoffman? See, that was the really first great movie. That was a great movie. As you'll recall, those who saw it, Dustin Hoffman and Rene Russo were suffering an epidemic, and they were getting divorced, unfortunately, as I recall. They weren't getting along in their marriage, although they were a married, super scientific couple. And at first there was one person infected, then there were 2 people infected, then everybody was infected, and then everybody was going to die. But then they made a magical vaccine that they helicoptered in, and everybody lived. Contagion, made 20 years later, actually used this formula. So now we get a much more sophisticated thing. In Contagion, they kept talking about R0 or R sub 0. And they were talking about the spread of infectious diseases where we have a formula that tells us how this is going to happen. We multiply beta, the efficiency of transmission. How easily does something go from one person to another? And let's talk about that just for 1 second. What bug do we think goes unbelievably easily from one person to another? The bug that causes chickenpox, varicella zoster. How many of you have had chickenpox? How many have been vaccinated for chickenpox? How many of you, now I know I'm going to embarrass you, how many of your mothers took you to a party with some other kids with chickenpox to get, They gave you chickenpox. Now, how did they know to do that? Because they knew this thing was so efficient that if you went in the room with another kid with chickenpox, 14 days later, you were going to have chickenpox. Your mother had some plans. She didn't want to be disturbed, so she gave you chickenpox. You might want to call her right after this lecture and complain. So we know beta for many of these pathogens, and that beta number is important to us. We'll talk about that for HIV. D, how long does something remain contagious? Do you remain contagious for a very long period of time or a very short period of time? Most of you have had a cold, and during the first couple of days of your cold, you're contagious, and then afterwards you start like doing your normal activities of intimacy with your friends. But during those first couple of days, like you wear a bell or something because no one wants to go near you. So D is important. Why is HIV causing such a massive pandemic? Because the people who are infected, and if it's a sexually transmitted disease, it's invisible, and people remain contagious for very long periods of time. It's a stealth pathogen that can go from one person to another invisibly. C, the number of people infected. For influenza or chickenpox, we can infect everybody in the room real quickly. But HIV is mostly volitional. You have to share needles, you have to have sex. It's a disease almost of choice or volition, but that doesn't stop it from being a massive pandemic. Now let's go back to Rene Rousseau and look at this formula. Tell me why that movie was wrong. Tell me why first there was one red dot, then two red dots, and you started vomiting blood and coughing up blood, and you fell over dead until you got your Rene Rousseau vaccine. Why does that not work with this formula? Who wants to volunteer? Yes, sir. Well, they're dying, so what happens with D if you're dead and buried? D is a very small number, right? The duration of time you can infect somebody is too small to sustain an epidemic. So the most fearful diseases that kill the host really quickly cannot sustain an epidemic. So Lassa fever and Ebola are not things we want to deal with because they cause you to vomit, to just die, fall over and die, but they can't sustain an epidemic. So we, in our thinking, have to understand the beta, the efficiency of transmission of HIV, and we also have to get rho, R naught, to be less than 1. So the whole goal of HIV prevention is to make that number small by making HIV less efficient, by reducing the amount of time people are contagious, or by reducing the number of people exposed to somebody infected with HIV. You now understand the entire global HIV prevention strategy. And actually, we could go outside, but we'll stay. So that's the whole thing on one slide, okay? Now, having said that, what do we know about HIV? We have 30 years of experience to understand everything about it. We know that infectiousness depends on the concentration of HIV called the inoculum, and the more HIV you have, the more contagious you are. So, and we're not so concerned about blood because it's a sexually transmitted disease. We're worried about secretions, semen and genital secretions. And not all the HIVs are the same. The HIV type they have in Africa, which is called type C, and there might be a slide about it in a second, it's more contagious than type B. So we begin to see why Africa might suffer a bigger epidemic than the United States. We have type B in the United States. They have type C in Africa. Susceptibility. There's some people who have hereditary resistance, and I think I'll tell you about that in a second. Some people have innate resistance. Very few people have acquired resistance, like immunity. So most people are susceptible. And I've already told you the way it's transmitted is sex, blood and blood products, mom to baby, before delivery, during delivery, after delivery, or breastfeeding. Now, this is important. Fear is a big driving factor in infectious diseases. And I think in a very tragic moment, I don't know every detail about this, and others may know more. I know in Hershey, Pennsylvania, that they asked a child there's something in a school in Hershey, Pennsylvania involved excluding a child, which reminds us of Ryan White, the poor child in the 80s and his hemophiliac brothers who were thrown out of their town because of HIV. But the point is we understand the transmission of HIV, and there's really no risk from other than these sources of contact. So why would you ever ask a child to leave the classroom? But it's the kind of fear that infectious diseases cause that lead to those behaviors. So these are all the routes of transmission. There's not going to be airborne HIV. There's not going to be some outer space event that's going to change the world. This is the disease we face. It's bad enough as it is. This is how the transmission event actually occurs. This is semen. HIV is in the semen. This is the vaginal mucosa. This is a cell. HIV doesn't have a brain. The virus has an envelope. The parts of the envelope that we're concerned about are those that can find receptors. We're concerned about two receptors, CD4 and CCR5. So the virus passes all kinds of barriers to find these two receptors. Once it binds to the cell takes it up, that one cell starts spreading HIV to other cells, and the person is HIV infected. Now, what would you think would happen if something was missing from that CCR5 receptor? Would you think it might be more difficult to infect that person? Yes or no? Are there people on the planet with something different about their CCR5 receptor? Yes or no? Right. 1 out of 100 people have a change in their CCR5 receptor where they're healthy, but they can't be infected with HIV except with great difficulty. They can still be infected rarely, but with great difficulty. Those are white people. So white people have a big advantage as a species, as a part of the species, compared to people of color. This change in the receptor, which occurred millions of years ago, and we don't understand why it occurred, helps to protect Caucasians from HIV. So now we're beginning to see the roots of an epidemic worldwide. We see Africans are having a different type of HIV, type C. We're seeing Africans rarely have this clade C, CCR5 receptor deletion. There are biological forces driving the spread of the disease. I'll skip that slide. And this is just to show you all these different types, and it shows you type C is making up most of the epidemic in sub-Saharan Africa, whereas almost all the infections in the US are type B. Now there's another thing you need to know. Can everybody follow what I'm saying? This is like pretty heavy-duty biology. It's not going to go on like this forever. But if we don't have a common language, it's hard to give this lecture. So I apologize. This is like a first-year medical. This is like a second-year medical student lecture. So I apologize. Nevertheless, I will continue. So, because I can't stop. Okay. Now the other thing that happens is this. You're in a bar minding your own business, and you decide to have unprotected intercourse with somebody else. And that person happens to have HIV infection. And that event, you're the unluckiest person in the world, and that event leads to transmission, which is not necessarily so efficient, but you're having bad luck that night. And we'll talk about what's called amplified transmission in a second. Then HIV infection occurs, but for the first few days it's invisible. We can't see it. But then once it stops being invisible, we can see the virus growing in the blood. And I want to show you that during during the first few days of infection, when you don't know you're infected, there's no defense against the infection. And this virus is growing as fast as it can grow. And it grows to make millions or billions of copies in all the compartments of your blood, of your body, all the blood, the semen, everywhere. While it's growing so fast, would you think you'd be more contagious or less contagious? Make a guess. More. You're incredibly contagious. We look at you as a super spreader. You don't know you're infected. You're growing virus that just came from somebody else. We know it can cause infection because it just caused infection in somebody else, and now it's ready to go to the next person. Furthermore, while it's growing so rapidly, it's integrating itself into your cells. So the reason we can't cure HIV is because during this ramp-up viremia, the integration event renders the disease incurable. Also, during that window of time, this virus is destroying gut lymphocytes in huge numbers. It's irreparably damaging your immune system. Ultimately, the virus reaches a set point, the copy number that you maintain untreated for the rest of your life. If you have a high copy number, are you more contagious or less contagious? More contagious. If you have a high copy number, do you die faster or slower? Faster. So now you understand the whole ball of wax for HIV. Ramp-up viremia, uncontrolled ramp-up viremia, ultimately fatal infection, depending on how high the virus is in your blood. So you have this infection at day 0 after your visit to that bar, and you're pretty well for several years, and then bad things start happening because you've had irreparable damage to your immune system, and as your immune system continues to deteriorate, first you get tuberculosis, and then we see another problem. TB in itself is a bad disease. It's a disease that's restrained by host defenses. HIV is destroying your host defenses. So now we have a double whammy. So what do most people die of on the planet? Do they die of HIV or do they die of tuberculosis? Many die of tuberculosis because they don't know they have tuberculosis, and that in and of itself can be a fatal disease, and they can infect other people with tuberculosis. So the first harbinger at pretty good immune function is TB, and then there's all these infections, including the first one that we saw, pneumocystis, the pneumonia that we saw in those gay men all those many years ago, and as the host defenses wane and more time goes on, you get sicker and sicker and sicker. And here's a slide just to look at TB worldwide and look at the density of TB, and where on the planet would you guess we have the most TB on the planet? Where we have the most HIV. Where do we have the most HIV? Sub-Saharan Africa. So we have a double whammy epidemic. So how did the epidemic get this big? I've told you. Infection D is unrecognized. Transmission efficiency is variable. That's the beta. A misguided belief that transmission is rare, and I'll get to that in a second, I think. And that will really drive an epidemic. Here are the probabilities of transmission. And let's just go slow over this slide. So we know that a mom to baby, if we don't treat the mom with antiretrovirals, that she's going to give her baby HIV 30, 40, 50% of the time. But we learned 15 years ago that if we treat the mother with antiretroviral drugs and reduce the concentration of virus, we can make the baby protected at some level. And now, with the right treatment, we can get the baby to get HIV less than 1% of the time. So that's a huge public health breakthrough. Needle sharing and blood. A needle can cause HIV about 1 in 200 times, just a needle that a doctor would draw blood out of, but a unit of blood will cause HIV 100% of the time. Tell me why a unit of blood causes HIV 100% of the time. Use a word I already told you. What's in the unit of blood? The virus, right? An infected unit of blood. What do we call the concentration? We call it the inoculum. Does a needle have a bigger inoculum or smaller inoculum than a whole unit of blood? The whole unit of blood is a huge amount of virus. You can't avoid getting infected. What about sexual transmission? Well, this is an article I personally wrote in 1997, and it's wrong, so I apologize. It was a long time. Again, most of you were not in college in 1997. I thought I was really smart when I wrote this article, or we wrote this article. And what we said was, well, look, like, and I'm not going to go into all this in great detail, but basically we said, well, look, sexual transmission's not so efficient. It takes maybe, and don't raise your hand for this, it takes maybe 1,000 episodes of intercourse in order for transmission event to occur. But 1,000 episodes of intercourse is a lot of episodes of intercourse. How many times a week do humans have intercourse? Well, it turns out there's a guy in Chicago who studies this. And he writes books named like Sex in Chicago, Sex in China, Sex in France. And his books show that everybody, younger people, and by saying I mean people 20 to 50, let's call them young. Let's call it 20 to 40. When they're sexually active, they have sex no more than about 8 times a month. That's only about 80 times a year. So that's about the norm for everybody living on the planet, right? All the heterosexual intercourse. That would require 10 years for a transmission event to occur. That doesn't make sense, but it made sense to me then. It doesn't make sense to me now. And it especially doesn't make sense if we look at this really tragic slide from my colleague Audrey Pettifor. I'll go slow over this slide. This is the prevalence of HIV in sub-Saharan Africa, but it's true of, this is South Africa, but it's true of most of sub-Saharan Africa. Green is boys, pink are girls. And what happens is the boys have a low prevalence of infection, 2, 3, 4%. By age 21, a third of all the girls get HIV infection. 1/3 of all the girls get HIV infection. So in the United States, if 1/3 of all the girls in this room had HIV infection, everything would be closed. We would stop everything. But this is what's happened in sub-Saharan Africa. Now, we've studied these girls very carefully and compared them to, Audrey Pettifor studied these girls very carefully in collaboration with a lot of other people. These girls are doing nothing different. Their sexual lives are just like everybody else's sex lives. So there's something different about the risk they're having. They're having sex 8 times a month just like everybody else. But their chance of having sex with an HIV-infected man is much greater than a girl living in the United States, especially if the sex is with an older man where the prevalence is almost 10%. Let's think about that. If you're in a bar in the United States, I'm going to have how do I say this politely? If you're going to have a relationship, and with that person, the chance of that person you're having a relationship is less than 1 in 1,000 they're HIV infected. But if you have the same bar in South Africa, and it's a man 3 or 4 years older than you, there might be a 10% chance that that man is infected. So this is a huge problem. And first there's the exposure problem, and the second thing is that number I showed you on the previous slide, 1 in 1,000, it makes no sense. So we came up with another idea. And this is, by the way, this is a slide that shows you from South Africa the frequency of sex 15 to 24, 10 times a month. Then it gets lower and lower and lower. And as you get older, it gets below the line because you're telling other people not, like me, telling other people not to have sex. It gets fewer and fewer episodes of sex. You see 59, only 7 times, less than 7 times a month, and then it gets smaller, smaller, smaller. Now, one other thought then is the idea that since 1 in 1,000 doesn't make sense, we kind of think of this then, there must be an amplification factor. And we call this amplified transmission of HIV, where other things can make people more infectious. If the blood viral load is higher, you become more infectious, or if the genital tract viral load is more infectious. So acute infection, the first few days, you're very infectious. STDs, like gonorrhea and chlamydia and all the STDs, render the person with HIV more infectious, and we'll talk about that in a minute in more detail. Susceptibility. If you have mucosa, if the tissues that would be exposed to HIV are inflamed, they have receptors in higher number that can receive the HIV virus. So infectiousness can be greater in the infected person, susceptibility can be greater in the receptive person. This leads to amplified transmission, and instead of requiring 1,000 episodes of intercourse, you might require 100 episodes of intercourse or 50 episodes of intercourse. Now, let me bring up an uncomfortable topic just for 1 second, the anus. The anus is another place where people use for sex. We all know that. Anal intercourse is very contagious because the anus has so many receptors for HIV. Why does the anus have so many receptors for HIV? Because it's defending against infection from poop. That's not the clinical word, but so the anus is, so none of you, all of you, everybody in this room has to use their anus. I believe. And when you use it, you almost never, none of you have ever had an anal infection. How is it even possible? Because so many bacteria are going over that tissue. It's possible because it's heavily defended. Every time there's a little break in the anus and everybody's, is this too gross, Ron? No. Ron appreciates this. He's a dentist. He appreciates this kind of. So the point is the anus is heavily defended. The very defense against infection provides cells that are receptive to HIV. So when semen is delivered in the anus, then you have a whole nother probability, much higher than when the vagina is involved or the penis. So these probabilities are really important, and it's not 1 in 1,000, it's 1 in 100 or 1 in 10, and that helps explain how we're getting this gigantic epidemic. Let's just skip that. So I'm going to answer your question, don't worry. So let me show you another view of this whole thing. So now we have sexual transmission of HIV, the concentration of HIV in semen, from actual work we did here over many, many years. For 30 years we've been working on this problem. For 20 years, we took 20 years to generate this slide. Here's like the ramp-up viremia of HIV, very high probability of transmission. Here's a person with very low set point. They're not very contagious. But as they get AIDS, if they're still sexually active, they have more virus in their blood, they become more contagious. Here's the set point. Somebody very contagious, somebody not so contagious. Here's what happens with STDs. Somebody's very contagious with acute infection, they're not so contagious, but now they get gonorrhea. And all of a sudden with gonorrhea, so much inflammation, they start shedding more HIV. And then they become more contagious again. This intermittent ramp-up increases in contagion. Okay, we're going to stop and answer that question, and then I'm going to tell you a little about STDs, and then we'll get into prevention. Yes, sir. Yeah, I'm going to repeat your question.
Like 7 slides ago.
I'll remember my slides.
With the data on the women and men in Africa contracting HIV, is there any optimistic way to interpret those large error bars as you get to higher ages, or is it?
Yeah, so I'm going to repeat your question. So his point is this. As we've done studies in sub-Saharan Africa and looked at women and men in Botswana, in Malawi, in South Africa, there are big error bars, confidence intervals that are very large. But however we handle the confidence intervals, the phenomenon is this. Young women are at tremendous risk. Adolescent women living in South Africa, unless they have sex with boys younger than them or the exact same age, start acquiring huge concentrations of HIV. In some parts of South Africa, in Vulindwela, it's 50%. Half the girls are infected by age 21, which is what makes those large error bars. The men are always slower to get HIV because while they're sexually active, it's rare that they're sexually active with girls older than them, so they're usually younger girls, and so they acquire HIV much more slowly. Now, for every HIV transmission, if you have, I guess it's a concept I'll come to in a few minutes. So the error bars you can ignore. that the women at adolescent ages are at grave risk, and it's a huge problem. Other questions before I go on? Okay. So the STDs. So if HIV is 33 million, the STDs are 400 or 500 million STDs. Hundreds of millions of STDs. There are 4 kinds of STDs. Some that cause mucosal inflammation, some that cause changes in epithelial cells, some that cause genital ulcers, and some that use a genital tract to get into your blood, like HIV. HIV causes no genital tract changes, it just gets into your blood. So how do STDs increase HIV transmission? They reduce the physical barriers. They make holes in your tissue. They increase HIV in genital lesions and semen. They can evoke a more infectious variant of HIV, and most importantly probably, they make the tissues inflamed so that the vagina or the penis look more like the rectum because there's more receptive cells. As the tissues get inflamed and the host tries to deal with the STD, it's setting itself up to acquire HIV. So you get into a double whammy situation again. These are different ulcers. This is the ulcer of Chancroid. This is syphilis, which all of you have heard of. This is herpes, which is a very common disease in the United States. Genital herpes, about 1 in 5 Americans have genital herpes. Most never have symptoms. They get the infection, they remain asymptomatic, but very commonly they still shed herpes, so we keep an epidemic alive. It's an iceberg effect. Only 10% of people with genital herpes are aware that they have it. 90 or more percent don't know they have it because their first episode was missed and they never know they really have this infection, but we can see it if we look. Now the point is this. So let's think about the same bar again, or that situation. So you're having sex now with a partner that forms a regular partnership. Unbeknownst to you, that person has HIV and herpes. Herpes is more infectious than HIV. Fewer episodes of intercourse are required to transmit herpes. And there are many herpes viruses. Here we're talking about HSV2, herpes simplex 2. So in the first episode of intercourse, or the second episode of intercourse, you acquire herpes. Then 3 episodes of intercourse later, now that the herpes has taken hold and you have inflammation, you're set up to acquire HIV. So does that make sense? So this is how this epidemic works. Now, just about UNC. So if you were going to study STDs and HIV, you wouldn't do it in Chapel Hill because HIV is rare and STDs are fairly rare. In order to do this, more than 20 years ago, we started working in sub-Saharan Africa. For UNC, historically, our flagship country has been Malawi. I have to make an announcement that I think is important that Ron has been my partner on, that Zambia is a country very close to Malawi, 4 hours away, a bigger country, and we've recruited a fantastic team of physicians from Zambia that have started a new program in global women's health. More than 7 doctors, 400 people have joined us to work on women's health in Zambia. We're very excited about it. So it even dwarfs our Malawi program. And the leader of that is a very famous guy named Dr. Jeffrey Stringer, who joined our faculty. All of these people joined our faculty January 1st. And there's a press release that's coming out this week announcing the global women's health program, and we're terrifically excited about it. But most of my work has been in Malawi, as have many of the dentists and others. So it's a very poor country of 10 million people, 90% rural. The per capita income is less than $200 a day. There's about 900,000 people, about 10% of the whole population, out of 10 million are living with HIV. The adult prevalence is from 15% or greater. But we work at an STD clinic. And in the STD clinic, when we see somebody with an STD, the probability that they also have HIV is 50%. So every other person we see with an STD has HIV because of this co-transmission probability. This is what it looks like in rural Malawi. This is our original UNC project sign from 1991. This is our new sign of partnership with the government and our clinic where we take care of about 10,000 people called the Lighthouse Clinic. All of this is led by a gentleman on the faculty named Irving Hoffman and other people on the faculty who've done a terrific job. This is a building built with the help of the federal U.S. government and the other donors, UNC donors, called the Tidziwi Center. This is a building we're allowed to do research in, or can do research in. This is the only medical classroom in the city, essentially, which we use to teach lots of different students. This is we have 4 quadrangles of laboratories that look like this. It might not look like much, but this is what you need to do research in this country. And this is in many ways what we're most proud of. The Health Science Library at UNC is fantastic, and that's the UNC homepage. So there's a satellite on the roof, And people working in Malawi are part of the UNC library, and they can get all the articles and books and everything else you can get, they can get through that homepage. So I can't say enough good things about the global library. So this is where we've done most of the research that I have talked about and that I'll continue to talk about, but in collaboration with a very large number of people. So I think I'll skip that. Too much information, even for me, too much information to give you. No one can do it. So where are we going? Now we're going to say, where is all this going? Where are we going? One, treatment. So here's what happens up to now. You were living in Botswana, which is a rich country, and you were going to get to live to be 60 years old. But then we introduced HIV in Botswana, and you get to live to be less than 50. You're born in Malawi today, and your lifespan is less than 40 years. Now, I need you to really stop and think about that. What if you're in class today and you thought you were only going to live to age 40? I don't believe you'd be doing, first of all, I don't think you'd be in class, no offense. But even if Ron took attendance and used tough love, there would be a lot of people saying, I'm only living to 40, I'm out of here. So this kind of death rate is just unbelievable. But then there were the pills. And at first there were there was one pill called AZT, then there were a lot of pills, and then ART became easier, less toxic, and much more potent. And we went from all these pills to one pill a day. And when we went from all these pills to one pill a day, we went in the United States from deaths like this, 96, huge death rate from HIV, to no deaths. And the use of ART went up, and it's because of ART that all these deaths stopped. For me, in 1985, when I was working at UNC Hospital, which is 1,000 beds, 14% of all the patients in the hospital had HIV, and 100% of them died. So it was a terrible time for us. Now, we rarely have a patient in the hospital. We have about 25,000 people in North Carolina living with HIV, and death is rare because it's a chronic disease because of the pills. The coffin makers in Malawi are gone. They're all furniture makers. So those who've recently gone to Malawi see chairs and couches and other devices because around 2000, we said everyone's got to receive these drugs. Before 2000, the world was divided into those who could get the pills and those who couldn't get the pills. Now everybody gets the pills. In China, where they decided to deal with their epidemic, they make the pills free. So if you identify yourself as HIV infected, you're in a program where you get free pills. Same thing in Brazil. So one of the tensions now, if you're a young person, is dividing the world into people who die of a treatable infection that don't need to die because of the cost of the pills and the difficulty of distribution and so on and so forth. But these pills are one of the great breakthroughs of the 20th century. The survival benefits have been studied, and in the United States alone, it's estimated there have been more than 3 million years of life saved by the availability of these pills, which are now one pill a day. This is just the treatment worldwide. Before 2000, people said Africans can't take pills. They don't have water to take them with, they can't tell time, whatever. And then after 2000, people said it's unacceptable, and you see a steady rise all over the planet in people getting antiviral therapy and living chronically with this infection. Now, we haven't treated everybody. We call this the treatment gap. These are the people on ART as of 2008. It's more now. It's almost 5 million now. And by the way, the U.S. is the biggest payer of people on ART worldwide through Bush's program, George Bush the Younger's program called the Presidential Emergency Plan for AIDS Relief. We're the biggest donor towards providing antiviral therapy to people on the planet, but we still have millions of people who could use these pills and aren't yet receiving them. Now, this is treatment for the individual's benefit. We're going to come to another issue in a few minutes that will change our thinking a little bit about this. So where are we going? Number 2, HIV prevention. So for every person who we detect who's infected, we estimate anywhere from 3 to 6 more people will become infected. Now just think about the numbers. That means, but this can't be true anymore because it's leveling off. But when those numbers were estimated, that was what was happening. You found an infected person, a year later you find 3 more infected people. That leads to a huge pandemic. So we need to prevent HIV, and we're going to have 4 opportunities to prevent HIV. Again, this is everything on the planet in one slide. Opportunity 1, keep people negative. Take HIV negative people and keep them uninfected. Most of our energy has been spent in this arena. Advertising, telling people to have safer sex, and trying to treat STDs effectively, trying to get people to use condoms. But in all candor, condoms are difficult to use, and they're not popular devices, and they're never going to be really popular devices. And don't raise your hand for this, but anyone who's used a condom knows that they're not the best thing for intimacy. I don't know how to say this better, but but yet they're important devices. So this has been imperfect. But as we try to get people to have safer sex behavior, we've focused a lot on condoms and STDs, treating STDs, identifying treatment as volitional interventions. But then we came up with another thing, and we need to talk about the other thing, circumcision. We'll come back to that. Then we have vaccine development, which we'll talk about, I think, for a second. We have post-exposure prophylaxis, vaccines and pre-exposure prophylaxis, and treatment of the infected person. All that we need to talk about. So these are our options. The unexposed person, the moment of exposure, the moment after exposure, and what do you do with a person who's infected? This is all of our strategies. Now, because I'm not going to talk about it in detail, I'll tell you again, our colleague Audrey Pettifor is doing very important work with what are called structural interventions. What's that? It's creating an environment where you benefit from, where the government helps you to benefit in some way from doing the right thing. What are examples of that? Seatbelt laws. Deaths from car crashes going through the windshields went down dramatically when the government said you get a ticket if you're not wearing your seatbelt. Child restraint laws, car seats. Before that, little kids were filling up the emergency room. Now kids are in restrained car seats and they don't die. Those are structural interventions. Audrey's doing a giant study in South Africa offering adolescent girls who are uninfected transfer of small amounts of money to remain uninfected. These are called cash transfers. This is a really popular thing. It might seem like crazy to provide a school uniform or some money to these girls, but this is a powerful intervention that's being studied. Now, what about male circumcision? This is a really important lesson. This is not a new idea. Here's some Greeks circumcising some guy, Egyptians, circumcising some guy a very, very long time ago. And for years and years, we made the observation that in places where many men were circumcised, over here, percent circumcised, 100%, we didn't see men with HIV infection. Whereas where men were not circumcised, there were a lot of HIV infections. But we said, but the men who are living here circumcised, they're Jews and Muslims. They never have sex. And so it must be that behavior is protecting them, or God's will, or something. So, but then, and this went on for years and years, this discussion of what's called ecological data. And the ecological data was not hidden from us. So then ultimately, 3 randomized controlled trials were done, and they showed that the foreskin has a huge number of receptors for HIV. And somehow HIV is the only bug on the planet that learned to use the male foreskin to get into the body. So when you take away the foreskin, you've removed a huge place where HIV can be acquired. And so circumcision has proved very effective. About 50, 60, 70% reduction of acquisition of HIV once circumcision has occurred. So the Gates Foundation, seeing this, said, look, let's just circumcise everybody. And they rolled out huge amounts of money in Africa for adult circumcision and are now trying to convince African moms to circumcise African babies at birth. The benefit won't be realized for 14 to 20 years, but there will be a huge benefit if we circumcise enough people. Now, circumcision, of course, can't work for everybody because Chinese who have a one-child policy, they're not going to circumcise their babies. Their small, precious one child, who's mostly a male child for a variety of reasons, they call a baobei, a precious jewel. They're not circumcising that baobei. Second, Indians aren't going to be circumcised because Muslim Pakistanis are circumcised. They don't want to be confused with Muslim Pakistanis. So there are cultural reasons why circumcision is not for everybody. Furthermore, there's this. Not everybody, where is my foreskin idea? Well, I'm telling you that circumcision is a really good idea. There's another guy who could come here and talk and say this is disfiguring. Sex will never be the same. Once your foreskin's gone, you don't know what you're missing, so to speak. Which is a good pun, by the way. So the bottom line is this. All organized bodies of medicine that are concerned about AIDS prevention recognize male circumcision as a big part of prevention. The more men that are circumcised, the less HIV acquisition can occur, and those men are not then going to be able to infect women. Okay, the next thing that we could do is make a vaccine. That would be a really good idea, or we could have pre-exposure prophylaxis. Let's talk just for a minute about vaccines so you understand it. Here's what we really want to do. This is like our chickenpox vaccine or many of our great vaccines. You've seen this slide over and over. Mind your own business, get HIV, get a set point. But here's a person who's been vaccinated, and this vaccine works so well that you're protected. and you have unprotected sex and you don't get HIV. This is what we want to do. We've been unable to do this. So instead we tried to make a different kind of vaccine. We tried to make a vaccine that would let you get infected, but when you got infected, the concentration of virus in your blood would be lower so you couldn't spread the disease to the next person, if that makes sense. Okay? We failed to make this vaccine. And so 2 years ago, in a very famous study from Thailand, we saw the first beginnings of success in an AIDS vaccine. So this is the vaccinated people, this is the placebo, and this is the vaccinated people with a vaccine, and there was 30% protection from the vaccine. That's not enough protection, but we have a clue of why this vaccine provided protection. So now the vaccine, and this is making these antibodies that I tried to show you, that neutralizing antibodies, that's sterilizing immunity. So there's a race to make a vaccine, and in your lifetimes there'll likely be an HIV vaccine. Will it be 100% effective like measles and chickenpox and those vaccines? Probably not. But will that vaccine be used? Absolutely. We say that a vaccine that's more than 50% effective will start delivering, just like circumcision, 60% effective. Putting all the tools together to try and end this pandemic. Okay, what I've worked on the hardest as we move through this discussion, and I'll slow down now because this is complicated, is the use of antiretroviral therapy, not for individual benefit, but for the public health benefit. Can we use antivirals for public health benefit? So we have 3 options. Post-exposure prophylaxis, where you stick yourself with a needle, and right after you stick yourself with a needle, you take pills as fast as you can trying to stop the growth of the blood. Do you guys think we do that if you stuck yourself with a needle, yes or no? Or if you were raped? Yeah, absolutely. If you go to the hospital and were raped or exposed to HIV, if you're in our clinic or the dental clinic and somebody sticks themselves with a needle, those pills are in a drawer. We take those pills 10 seconds after you're exposed. Those pills, we think, reduce the transmission probability from about 1 in 250 to 1 in 10,000 or less. So this is a big deal. But what about another idea? What about an idea that you're going to go to a bar, and I shouldn't use the bar metaphor, I apologize. That's the only way, I'm too old to think differently. You go somewhere, I don't know if people go to bars. Do you know the answer to this question? You're teaching this course. You go somewhere where you're going to have unprotected intercourse, okay? And you're not only that, you're going to have really high risk unprotected intercourse for whatever reason. I don't encourage it. And you're not going to use a condom. Well, what if we gave you antiviral pills before you had unprotected intercourse? We call that pre-exposure prophylaxis. So does that stuff work? Well, this is our maternity clinic in Malawi. There are 30,000 live births a year, and when we started treating the moms with antiviral treatment or treating the babies with antiviral treatment, the probability the babies would get infected went way, way down. And so we got healthier and healthier babies from this. Skip that. So this led to the conclusion that these antivirals, either by treating the infected mom or by treating the baby right after delivery, could protect from infection. So the maternal part of this was the first clue this was a really good idea. So then we had development of 2 other strategies. So if the pre-exposure prophylaxis idea was a good idea, okay, let's take the antiviral and instead of taking a pill, let's put it into a gel. So investigators in South Africa, the Kareem couple, took the drug tenofovir, which is a potent antiviral. They put it in a gel. It's a liquidy stuff. It's in this syringe, and they said to women, use this in your vagina every time you think you're going to have sex. Use it just before sex and use it just after sex. And they published a paper in Science 2 years ago that said that they were able to prevent 44% of HIV infections by using this gel. That was considered a huge breakthrough in all newspapers at that point in time. Subsequently, another study was done using the same gel but using the gel daily. That's called VOICE. When that study was done, the study was stopped because it failed. Futility. So, does the gel work or not work? We're not sure. So a 3rd study is being done right now. But what people are trying to do with this gel is to give women a tool that they can control in their purse to prevent HIV acquisition. It's not going to prevent other STDs, but it could prevent HIV. Well, if the gel is a good idea, it's kind of potentially messy. Plus, you have to use it in a private part. Why not take a pill? So a lot of pill studies have been done. So the first pill study was called IPREX. This is a study of men who have sex with men in Peru and the United States. And in this study, IPREX, men either were in a placebo group, taking a placebo, or another pill called Truvada every day for a year. And the IPREX investigators studying MSM, men who sex men, saw 42% protection. That's not perfect, but it's incredibly better than nothing. So this was another clue of success. Then later this year, 2011, a study in women showed 63% protection from the same pill, and another study in women and men showed 73% protection. So all of these studies lead us to be really excited, thinking pre-exposure prophylaxis, while difficult, is a tool we can use, because we were looking for every tool. But then bad stuff happened. FemPrep, a trial done by Family Health International in the park, stopped because the same drug worked. Voice, tenofovir arm, stopped because it failed. Voice, tenofovir gel, stopped because it failed. Truvada, ongoing, but we don't know the answer. So this is a conundrum. Does this stuff work or not work? So the reason we think it might not work is simple. If people don't use this stuff and they lie to you about using it, it can't work. Adherence, adherence, adherence. It's a really big, important thing for all trials. Our couple special, tissue levels, all this stuff is going on. And next week, we'll hear a lot of results at a meeting in Seattle related to the slide I just showed you. Does PrEP work? Is it a good idea? Can we really use it? What's its public health utility or not? Let's skip that. So that leads me to my own work, treatment of the infected person, which we have worked on at this university for more than 20 years. A huge number of people from the School of Pharmacy, from the School of Public Health, from the School of Medicine, from the School of Nursing, they've all worked together on this one idea. And it's a really simple idea. It's not rocket science. When you treat the person for their own benefit, can you render them less contagious? Why do we think that might work? Well, first of all, we saw it work in women. Second, what happens when you get tuberculosis? We put you in the hospital for 2 weeks, we give you some anti-tuberculous pills, we kill the bugs in your lung, you take the pills for another 9 months, but we send you home. We've rendered you not contagious. So the question is, can you treat your way out of the epidemic? So we did many, many studies, which you'll be very glad I'm not going to show you. And among those studies, one that I think deserves attention is the semen study. This is from the, actually the study was done in the 90s. This is men and the semen HIV copy number. This is the percentage of men in whom we can detect HIV in semen before we treat them. So we're counting the HIV particles, essentially. Then we give them antiviral pills. While we can occasionally still recover HIV, you can see how dramatically less HIV there is. So we showed, as did others, not just us, that when you treated people, the concentration of HIV in the genital secretions was reduced. We call that biological plausibility. So after 10 years of work developing biological plausibility, we also were studying which drugs we could use. Why would you think the same drugs that are best for your health are best for public health? They're not. So we had to find drugs that concentrated in the semen and use just the right drugs. So after about 10 years, literally 10 years, we then decided we could do a clinical trial. And we wanted to do a clinical trial in humans to ask 4 questions. Do antiviral drugs prevent HIV transmission? But we needed to know how much do they prevent transmission? And are they durable? Do they prevent transmission for a month, or 6 months, or a year, or 5 years? What do we tell people who are infected? They're terribly stigmatized. They want to have children and families, especially in Africa. What do we tell them about, are they rendered less contagious when we treat them? Can we reduce the population level of HIV by treating people? And if we're going to try and treat our way out of the epidemic, what are the barriers? These are the questions our group and other groups have been asking. So in order to do this, we decided to do a randomized controlled trial. This is a really difficult thing to do. So we said we were going to randomize people ethically to either receive immediate antiviral therapy as soon as we found them, or to be delayed in getting their antiviral therapy till their immune status went down a little, but not enough to hurt their health. Does this make sense? So one group, as soon as we find the people with infection, they take a pill. The other group, they wait. They still are going to get pills, but they're waiting a little while. Now, what are we looking for? They have to have a partner, and their partner has to be sexually active with them, and their partner has to be HIV negative. We call these discordant couples. So we're looking for thousands of discordant couples to randomize into 2 groups. This obviously is a big, and these people have to get antiviral drugs, and they have to take just the right antiretroviral drugs. They have to take them every day, and they have to be free. So you can imagine this study is expensive. I'll tell you right now, the study cost $78 million, and the drugs cost $30 million. So this is not something you do at home. And it takes a long time to try and get this off the ground. So the primary endpoint of this study was to look at transmission events. and to say, if we see a transmission event, did the person infected actually give it to the next person? These are called virally linked transmissions. Because remember, the person we see infected could have had sex with somebody else. So we have to have the virus line up perfectly. Does this make sense? The second question we asked is, did we make the people taking pills sooner, the early group, did we make them healthier? So we're asking two questions at the same time. This study, as I said, took forever to do. I could go into this in great detail, but I won't bore you with it. This is just a timeline of all the stages we went through to do this study. And in the end of the day, we screened 10,000 couples to enroll 2,000 couples. And those 2,000 couples were randomized, as I told you, at 13 sites in 9 countries, in Asia, Africa, and South America. We over-enrolled Africa, almost 1,000 couples in Africa. On April 28th of this year, we had what's called an oversight board. So for 10 years, if I go back a slide, so from here to here, we were doing the study, but we had no results, okay? So no papers, no abstracts, no results. So on our 11th meeting with because all the results are blinded to us. At the 11th meeting of the oversight board, they said, we have to tell you something. Now, they had told us stuff in the past. For example, they had told us, what if the couple breaks up? What happens when they don't have a partner? Can you help them find another partner? Which is a weird thing for them to ask us, right? Remember, their HIV negative partner is gone. They say, well, where's the partner going to come from? Like, how am I going to find a partner in Thailand, you know, for an HIV infected person? But nevertheless, we did the study over 10 years, and on the 11th meeting of this organ, the DSMB, they said, the Data Safety Monitoring Board, they said, we have a result, but we can't tell you the result. So we thought the study had failed, and we started going to the airport, and I guess I'll show you a little film about this, and then they said, no, you've got to come back to the NIH. And then they told us that what they wanted to tell us was that we had stopped transmission in 96% of the time. There was only one transmission event in all the couples we were studying, and that transmission event probably doesn't count. It was like 100% effective. And this became a huge deal. The treatment for prevention becomes a game changer, according to UNAIDS and every other organized body in the world. Hillary Clinton makes it the cornerstone of the U.S. program to prevent HIV worldwide. Science calls it the breakthrough of the year. So this obviously was a very unusual event for people working for 20 years in this problem. The way I'll end this discussion and then answer your questions is to show you a movie UNC made that I think is really good, that conveys this study, which we spent so much time doing, and because I like the movie and because it's about me. So. When you're seeing patients, for example, you have so many patients in a day, you're done at the end of the day. But in this kind of research-oriented career, you're never done. So I guess if HIV disappears from the planet, that part of the work of infectious disease specialists will be done, but there'll be other work to do. It's not impossible we'll see the end of an epidemic in my lifetime. My name is Mike Cohen. I'm a professor of medicine, microbiology, immunology, and public health at the University of North Carolina at Chapel Hill, and I direct the Institute for Global Health and Infectious Diseases. I've always been a researcher, and I've always worked internationally. The kind of research I was doing had to do with the transmission of infectious diseases, especially sexually transmitted diseases. The progress that's been made in HIV disease is really quite remarkable given the short time frame, a 30-year time frame, and we've gone from not understanding what's causing a disease to knowing so much about the agent and having such capacity for proper treatment, for good prevention, and ultimately working towards curing the infection. And after about 10, 12 years of research, we said, this is worth testing. So in 2000, we began to develop this idea, and in 2007, it took a long time to get the resources necessary to do the trial. 2007, we launched the trial that is enrolling couples where one person was infected and the other person was uninfected. We call these discordant couples. We enrolled these couples, actually nearly 2,000 at 13 sites in 9 countries. And again, the question was very straightforward. If we treat HIV in the infected person, do we render them no longer contagious? Or to what degree do we render them not contagious? We had no idea any results. It was all blinded to us. So when the oversight board actually said, we have a recommendation, but we can't tell you the recommendation. You'll have to hear the recommendation later. And we had thought the study had failed. We thought the recommendation had something to do with failure. But the same day, we went back to the NIH and learned that the study was a terrific success, that we had proven our hypothesis, that antivirals could stop transmission. As soon as we saw the results, immediately we indicated that the drugs would be available to everyone in the study. Now, for me personally, it was quite an amazing moment. When you're involved in something for 20 years, as I've been involved in this work, it's kind of like a day at the office, right? I mean, every day I would go and work on this study, literally every day, 7 days a week for about 20 years. So having a very positive result that people have called a breakthrough, other people have called it a breakthrough, that Michel Sidibe, in charge of UNAIDS, has called it a game changer, as have other leaders of the NIH, and that The Economist used this particular study as catalytic for its cover, talking about the end of the AIDS epidemic. It's pretty rewarding, you know, after 20 years of work, pretty exciting. But we're still going to the office every day. This study's ongoing. We're trying to understand all that we have learned and will learn going forward. We're trying to participate in policy issues that relate to this study. It's quite complicated. So I think it's obvious from the public reaction this was an important observation, and we're really proud that we could do the work, but it's ongoing. Okay, so in summary, we have now been through enough of this tech. We've now been through like where this started in 1980 or before, UNC's role and the work that we've done here, where we are now, and the next 15 or 20 years will be interesting. The goals will be to provide treatment that's even better than we're doing already, to provide prevention strategies that embrace what we know how to do and make a vaccine, which we're very involved in, to try and cure the infection, which David Margolis on our campus is really a world leader in that. So it's an exciting time for investigators who work in this field. But for most of us on this campus, as I said, it's been an opportunity to do what we think is important work for all these years and make a contribution. And my job is to try and convey all this to you in like 1 hour and 10 minutes. So I will stop and answer any questions that you have. So thank you for listening. Thank you.